All right, I want you to think about this with me concretely. Let's say you passed all your exams, step 1, step 2, step 3, in residency, completed residency, you're now out in private practice, a thriving private practice, a good part of town, nice. One day, patient comes in to see you, some underlying anxiety says, doc, I think maybe I have HIV. You trot out the then current test for HIV, the results come back and the results say, positive test, they have HIV. Now, as a quick aside, now you have before you one of the hardest jobs in medicine, right? Delivering that bad news. Now look, folks, whenever you deliver bad news, there's some things to keep in mind. If you do a quick search, you're going to find a lot of contradictory advice in terms of delivering bad news, but there's just one thing I always want you to remember here. Whenever you deliver bad news, always warn first. Don't walk in and say, here's the news. Walk in and say, in essence, I'm sorry, I have bad news, pause, and then deliver the news. The warning, the pause before you provide the information gives people a chance to, mentally and emotionally prepare themselves for this negative news that's coming, right? Just basic medical practice here as we're talking. So you walk in, you say to the patient, have a test result, and well, it says you have HIV. What the patient's going to say next, in some very real sense, is a sentence very close to, doc, are you sure? Because denial is the first line response to bad news. Well, when the patient says, are you sure? What they're asking you for is what we call positive predictive value. Positive predictive value simply says, how believable is a positive test? How much faith or credibility should we give a positive test? Some positives are very believable. Some positives are less believable. The question is, what percentage of the positive people actually have the disease? Because not all the positives will be correct. This is not sensitivity. Sensitivity is, did you identify all the disease people? Of all the disease people, how many did we find? Positive predictive value is, wait, of all the positives, how many are diseased? The formula once again uses the rule I gave you, trues on top divided by everything. In this case, true positive divided by true positive plus false positive, or again, true positive divided by all the positives. Everything in the calculation for positive predictive value is a positive. Take a look here. Whereas for sensitivity and specificity, you remember I did column calculations. Here for positive negative predictive value, given the standard table, these are row calculations. For positive predictive value, trues on top, divide by everything. In this case, that's 850 divided by 1200. Notice I'm not thinking about the negatives at all. Forget the negatives. If they're there or they're not there, they don't matter. When I'm talking positive predictive value, all I'm going to do is hone in on the positives. Now, by the way, in case you haven't caught it, the then secret to doing these screening test calculations, sensitivity, specificity, predictive value, is to first decide what to not look at in the table. For sensitivity, we don't look at the healthy people. We only focus on disease. For specificity, we don't look at the diseased people. We only focus on the healthy. For positive predictive value, we don't focus on the negatives. We only focus on the positives. Let's take a look here at what we have for positive predictive value. You do the math here. You find out we have 850 divided by 1200. It comes out to 70.83%, or let's call that 70%. The patient says, doc, are you sure? Your best answer is there's a 70% chance I'm right. Or a better way to talk to patients is probably to say there's a 7 out of 10 chance that I'm right. That means 30% of the positives are wrong. Let's do it again. That means 30% of the positives are wrong. Finding disease, then are you concerned about sensitivity or positive predictive value? You're concerned about finding all the disease people in the population? Then you're concerned about which? Sensitivity or positive predictive value? That'd be sensitivity. Hey, but now you have a result, right? Now you have a positive result. Are you concerned about sensitivity or positive predictive value? Quick. I have a positive result in hand. What am I concerned about? Sensitivity or positive predictive value? Right, positive predictive value. Sensitivity is about finding all the disease that's out there. Positive predictive value says, I got a result for this patient in hand. How believable is the result? Finding all the marbles is sensitivity. Being sure that what I found is a marble is positive predictive value. Finding every single person in India with TB is sensitivity. Finding out whether this particular person in front of me actually has TB is positive predictive value. Sensitivity and specificity are for test selection, as I suggested. Positive, negative predictive value for test interpretation. We call sensitivity and specificity pre-test probabilities. Why? That's how we select the test we're going to use. We talk about positive, negative predictive value as post-test probabilities. Why? Because that's how we interpret the result we have. Sensitivity is epidemiological data collection. Epidemiological data collection can be so many different things, so no. I'm going to back you away from that. Once I have a result in hand and I'm trying to decide what to do with the result, sensitivity and specificity no longer matter. It's just predictive value. Let's do it again to give you a single sentence. When I'm selecting the test, I'm concerned about sensitivity and specificity. When I'm interpreting the result, I'm concerned about positive and negative predictive value. This issue, the test is not always right, is what I've been hammering on. And this is medicine. If you think every positive test is correct, I'm not sending anybody I know to be your patient, because bluntly, you're kind of an idiot. The test is not always right. And this is what makes medicine what it is. You can't walk in the room and give the patient the test result unless you know the positive predictive value. You can't walk in the room and give the result. The test is positive, because if you can't say how believable the result is, the conversation you're about to have with your patient, if the positive predictive value is 99% and the conversation you're going to have with the positive predictive value is 51%, are two really different conversations, are they not? You can't walk in the room and have the conversation unless you know how believable is the result. What's positive predictive value? Now that you've got a result, how believable is that result you got? I want to draw your attention to a couple things in-house. First, never ever answer any ethics question based on what you've seen in-house. It's pretty much a set of negative examples. On the other hand, they do two things really well in-house I want to draw your attention to. One, next time you watch an episode, you can find these on YouTube, wherever you are, I want you to notice on house, the doctors never ever talk diagnosis. They only talk differential. Never diagnosis, always differential. Why? Well, when we look at how good physicians think, that's how good physicians think. Good physicians talk about what the possibilities are, and then out of those possibilities, select based on the data what's most likely. But secondly, on house, they always deal correctly with laboratory screening test. In every episode, pretty much, they run some sort of diagnostic test, and based on that test, they decide the patient has a certain disease. And so based on the diagnosis, treatment is begun for that patient. And then everybody goes home, and overnight, the patient tanks. They have a seizure, there's blood spurting, they have some sort of horrible infection, and they come back in the morning. House sits down with the staff around the table and says, ha, we're wrong, the patient doesn't have that disease. One of the underlings inevitably says, but ran the test, and the test was positive. And House says, yes, but this only has a predictive value of 90%. Clearly, this is the other 10%. That's the doctor conversation, folks. The test is not always right. Let me put a pin in it right here. You understand the conversation I'm having with you. Everybody thinks screening test issues are about math. No, math is easy. They don't care about the math. Calculus is not even trigonometry. It's basic, add, subtract kind of stuff. There's nothing complicated about the math. It's about the concept. If you have trouble with the content, it's not because you can't do the math, it's because you don't understand what we're talking about. So let's do it again. What is positive predictive value? I have a result, positive result. How believable is the positive result? How much credibility should I give this result? If the patient has a positive test for HIV, how sure am I the patient actually has HIV? And if you're thinking well, the test is positive, they must have HIV. You did not listen to anything I said in the last 15 minutes. The test can be wrong. In fact, let's do it again. The test sometimes will be wrong. And getting a sense about how likely that is sounds like a pretty important issue for medical practice, don't you think? Let's picture a different kind of patient. Let's say you have a woman trying to get pregnant for the last several years without success. Now, having missed menses in her cycle, she comes to see you with great excitement. Why is the test not always right? Because what we do in the clinical setting to get information quickly and actionable is not as good as what we can do by making it the long-term, very expensive, detailed laboratory analysis that we do, right? Clinical tests are estimates that are good or bad estimates, but they're better than guesses. Is it human error? No. It's the limitations of human knowledge, right? I'm not going to answer any questions about residency and certainly your issues of getting into residency until I'm done with the lecture. So please hold those questions. It's not that we are stupid. It's not that we're dumb. It's not that we as humans make dumb mistakes. It's that there are limitations in our ability to grab reality, right? The tests we develop are the best ones we can come up with. But best doesn't mean perfect. The whole conversation about screening tests and positive and negative predictive value is a recognition that best will probably not be perfect. If you have trouble with that, you need to wrap your head around that. Because just because the test says the patient has the disease doesn't mean it's always right. There's all sorts of reasons why you might have false positives. They might have some other condition creating a false positive. They might have an interaction of different things. Can anything ever be 100% positive predictive value? Sure, but if it is, you probably didn't bother to run a test because it's probably obvious. I declare you're dead. Is that probably 100% positive predictive value? What is positive predictive value? Let me frame it this way. How sure are you about your diagnosis? Come on, aren't there sometimes you're absolutely crystal clear about the diagnosis? And aren't there sometimes you put the diagnosis out there, but you're not quite as sure you're right? You're talking positive predictive value. How certain are you that the diagnosis, they have disease, is correct? Positive predictive value. Let's think about another patient, female patient again, missed menses in her cycle, comes in to see with great excitement, says, doc, I think maybe I'm pregnant. You run the then current test to see whether or not the patient is pregnant. The results come back, and the results say she's not. Well, now once again, you have to deliver that bad news. How sure are you that this negative test, she's not pregnant, is correct? Again, I have an error here. This should be negative. People are actually healthy. What percent of negative people are actually healthy? There we go. Once again, the rule, trues on top, divide by everything. In this case, true negatives divided by all the negatives. Everything in the calculation of negative predictive value will be a negative. So we're now no longer caring about the positives. We can safely ignore the positives. All we care about now are the negatives. What's the rule? Trues on top, divide by everything. Notice the way positive predictive value is about the calculation in the row, negative predictive value is about the calculation in the row as well. In this case, we have 650 divided by 800, or 81.25%. I would call that 80%. I would say to the patient, when she says, are you sure that I'm not pregnant? I say there's an 8 out of 10 chance that I'm right. Or if you will, you can say there's a 4 out of 5 chance I'm right. It's mathematically the same thing. Positive and negative predictive value are about how believable is the result. When do you care about positive predictive value? When you have a positive test result. When do you care about negative predictive value? When you have a negative test result. Sensitivity and specificity, those are what we're doing as we're trying to find the disease people or identify the non-disease people. Positive predictive value, but interpreting test results we already have. We care about positive predictive value when we have a positive test result. We got negative predictive value when we have a negative test result. There's one other calculation I want to talk to you about. I'm going to talk to you about this just so you know what it is, but I want to start off by saying, really, there's no clinical utility to accuracy. You hear people talk about accuracy a lot in medicine. Probably when people are talking about accuracy, you have an attending on the floor talking about accuracy, they misspoke. They probably meant to say sensitivity or positive predictive value, and they chose the wrong term. What is accuracy? What percent of all the tested people are correctly classified? This is, unlike the other things we're talking about, the one calculation that uses the entire table, not just row, not just column, but uses everything. The rule we've been using, though, continues to be the same. Trues on top, divide by everything. That is true positive plus true negative divided by true positive, true negative, false positive, false negative, or I'm really lazy, what's a single letter I can write that means everything? N. True positive plus true negative divided by N gives you the accuracy. You do the calculation, you end up at 75%. 7.5% of all the people, excuse me, I said that wrong, 7.5 out of every 10 people are classified correctly. Okay, now that's what accuracy is, but stop now for a minute. Can you think of a clinical use for accuracy? You don't really care, do you? We don't care about how right we are overall in medicine. We care how right we are for something of our concern. How good are we at finding the disease people? Sensitivity. How good are we at finding the healthy people? Specificity. How believable is our positive test result? Positive predictive value. How believable is our negative test result? Negative predictive value. And how often we're right overall? For research purposes, that might be useful, but for clinical work, really, it's useless. Who cares? When you hear clinicians talk about accuracy, we don't care. So, if I want to have a test that finds all the disease people, what am I concerned about? Sensitivity or positive predictive value? If I'm concerned that when I say someone has a disease, they actually have it, what am I concerned about? Sensitivity or positive predictive value? That's an accuracy as we're using something, and we're not trying to decide whether they have or don't have appendicitis. We're deciding, are we making the incision at the right place? It's not different use of accuracy. The English word is the same, but the meaning is in a totally different context. Someone's pointing out to me in clinics we use positive predictive value. Of course you do. Why? Because somebody's already told you what test to run, and now you're concerned just about using the result. But here's a question. Suppose you were concerned about you had 4 or 5 tests, which one you should use. Sensitivity or specificity will help you make that decision. Remember, sensitivity and specificity are about test selection. Positive, negative predictive value are about for test interpretation. Tell me the question, and then we can agree what the answer must be.